In this chapter, we will look at neoplasia. First, we'll begin with a definition of neoplasia. A neoplasia is new tissue formation involving the overgrowth of tissue and the formation of a neoplastic mass. Neoplasm is synonymous with tumor. Neoplasia refers to any widespread and potentially grave growth abnormality. It can range from mild to severe, with the most serious and severe forms being cancer. The rate or incidence of neoplasia is actually more prevalent than the numbers show. Many tumors are not found until autopsy, and these were never clinically apparent. We will look at tumor growth disorders, but before we actually look at disorders, we need to understand adaptive growth responses. These are actually beneficial and normal changes to tissues. The first of these is hypertrophy. Hypertrophy is an increase in cell size due to an increased demand on the tissue. This occurs when demand increases, but the cells are unable to divide. This is typical of our skeletal muscles and the way they respond to weightlifting. Hyperplasia is another type of adaptive growth response. Hyperplasia is an increase in the number of new cells to meet a particular demand. For example, we develop calluses on our hands with excessive use. One type of abnormal growth response, when we look at abnormal growth responses, these are altered tissue growth with structural and functional abnormalities. The first of these is metaplasia. Metaplasia is the conversion of one cell or tissue type into another. The new tissue is normal appearing and well organized, but it has a decreased functional capacity. This process is reversible. An example would be what happens in your lungs in response to irritants. The normal ciliated epithelial tissue will be converted into a thicker pseudostratified. And this is what we're seeing in the picture here. This would be normal lung tissue. In response to mild irritants, it would change into a thicker pseudostratified type tissue. This process, as you can see from the arrows, is reversible. Another type of abnormal growth response is dysplasia. With continued exposure to irritants, the cell's conversion will be more drastic. You will see more disorganized cell structure with pleomorphism. Morphism means morphology. Pleo means multiple. So the cells are going to have variable size and shape. The cells tend to be large, very large, have an irregular shape, and also have irregular shaped nuclei. They also exhibit an increase in mitotic rate. If the process is reversible, it is referred to be precancerous. If it is irreversible, then it is called a neoplasia. And again, we can see in this picture, this would be our normal lung, and then with increased exposure to irritants, we see a dysplasia development. Notice the difference between a metaplasia and a dysplasia. In the dysplasia, the cells are very irregular, all different shapes, and they have these very large irregular nuclei to them. If we can still reverse this back to the normal tissue, then it is called a precancerous state. But if it can no longer be reversed, then it is a neoplasia. This picture illustrates both. With the dysplasia, we can see the pleomorphism with all the irregular shaped cells. This picture, it has now progressed to a neoplasia. The cells are very abnormal, and they also have irregular large nuclei inside of them. There are two other types of abnormal growth responses. The first is aplasia. When you put a in front of a word, it means absence of. Aplasia is the lack of organ development, and hypoplasia would be an immature organ structure or the inadequate development of an organ. Both of these are due to genetic or developmental abnormalities. Next, we need to look at some basic tumor terminology. The first being the term oncology. Oncology means the study of tumors. When we look at the characteristics of tumors, there are two basic traits or characteristics we need to concern ourselves with. The first is growth pattern. Is a tumor benign or malignant? Benign means the tumor is growing very slowly and it has an orderly growth. It tends to stay localized and is non-invasive. A malignant tumor, on the other hand, grows very rapidly. It also has a disorderly growth pattern. It exhibits an aggressive invasion of the adjacent normal tissue, or it can spread to distant tissues. If untreated, malignant tumors usually lead to death. The second characteristic is the tissue of origin. This refers to the layer of embryonic tissue origin. If the tumor arises from ectoderm, which refers to the outer layer of the body or the skin, or if it arises from endoderm, which is the protective lining of our internal organs, it is referred to as a carcinoma. If the tumor arises from mesoderm, which means organ tissue, it is called a sarcoma. A leukemia is it is termed a leukemia if it arises from leukocyte-producing tissues. Next, we will look at some basic characteristics of tumor structure. When looking at neoplastic tissue, it may, if it is a benign tumor, or may not, if it is a malignant tumor, resemble the tissue of origin. You will also see biochemical changes. For example, a malignant tumor may lose some of their functional capabilities. You often see pleomorphism. Again, this refers to the cell shape, size, nuclei, and rate of mitosis. You may also see anaplasia. This refers to the pattern of change producing an earlier cell form. Another characteristic of a tumor is its stroma. Stroma refers to the connective tissue framework of the tumor. If it has or exhibits a loose stroma, it is known as a fleshy tumor. If it has a dense stroma, it is a more solid tumor. We also have to look at the vasculature of the tumors. This is the extent of blood supply and nutrients to the tumor. If a tumor is smaller than 1 millimeter in size, it has the ability to rely on diffusion from the normal surrounding tissue and is not in need of any additional blood vessels. Once the tumor is larger than 1 millimeter in size, now it requires angiogenesis. Angiogenesis is new vessel formation. This is regulated by tumor angiogenesis factor, or TAF. This material is secreted by the tumor and directs new blood vessel growth to supply nutrients to the growing tumor. Many tumors also secrete or produce products. Many times these products are the same as what the normal tissue would produce. These products may contribute to the specific characteristics of a tumor. For example, in the skin, with squamous cell carcinomas, you tend to see an increased keratin production and inflammation. In the kidney, with renal cell carcinomas, you see an increased erythropoietin production, which can lead to an excess in red blood cells. In the ovary, with ovarian carcinomas, you tend to see increased serous and mucus production. This results in cystic and jelly-like tumors. Next, we're going to look at tumor behavior. First, we're going to revisit the issue of benign versus malignant, beginning with some traits of a benign tumor. Benign tumors exhibit an increase in growth rate from that of the normal tissue, but tend to have a less of a increased growth rate compared to the malignancy or a malignant tumor. Benign tumors have an orderly growth pattern of expansile growth. They tend to exhibit a regular tumor mass. They have a fibrous connective tissue capsule with distinct margins. They tend to have a more favorable prognosis for the patient with good surgical removal with less damage to the surrounding tissues. Traits of a malignant tumor: they tend to exhibit a disorderly pattern of growth. They tend to be more aggressive and have a much more aggressive rate of invasion into the surrounding tissue. They tend to send these invasive fingers into the normal surrounding tissues. They have a very irregular shape with indistinct margins, and capsules are rare. As a result of this irregular shape and this invasive quality, they have a poor surgical removal. They also have a metastatic ability. This is the single most important characteristic that differentiates a benign from a malignant tumor. Metastatic ability is the ability of the tumor cells to shed from the original site, known as the primary site, and reestablish themselves at a distant site called the secondary site. The tumor tissue that develops at the secondary site is histologically the same as the primary site and not that of the secondary site. These two pictures illustrate a schematic of a benign tumor versus a malignant tumor. Here in A, we see a benign tumor, very orderly, regular shaped mass of tumor cells, and notice the distinct capsule around it. Malignant tumor, on the other hand, not as well organized. You can see these invasive fingers that are spreading into the surrounding area, and it does not have a well-defined capsule surrounding it. Now, there is a problem with trying to say and look strictly benign versus malignant, because occasionally there is an overlap between these sets of traits, and there is a wide range of expression of benign tumors and malignant tumors. The problem arises, for example, if a benign tumor has no metastases but looks highly invasive. So it has some traits of benign tumor, some traits of a malignant tumor. How do you identify it? Malignant tumors may be poorly invasive but highly metastatic. So again, they have traits of a benign tumor and some of a malignant tumor. The problem comes if these tumors are not diagnosed properly. What can happen is one can overtreat a benign tumor or end up undertreating a malignant tumor. Another behavior of tumors are their growth rates. There are two growth-related concepts that we need to understand. The first is generation time. This is the amount of time between successive cell divisions. Doubling time refers to the amount of time needed to double the number of cells or to double the tumor size. Often people think of these as being the same. They are not. Doubling times are longer, and they tend to increase with the age of the tumor. Now, why is this? A lot is due to the new cells that are produced. New cells are not reliable. New cells, when they are produced, some of them may go directly into the reproductive phase and produce more new cells. Some may go into a resting phase and not divide right away. Some may lose their reproductive capacity altogether, and others may die. 90% of all new cells do not go into the reproductive phase. Therefore, it will take several generation times to double the actual size of the tumor. Then, as the tumor ages, generation times do not show any change, whereas the doubling time becomes prolonged. Another behavior to look at is tumor invasion. This is invasion directly into adjacent normal tissues. This can happen via one of three different methods: pressure atrophy, tumor cell motility, or chemotaxis. The first of these methods is pressure atrophy. As a tumor expands, it puts pressure on the normal tissue. This interrupts the blood supply to the normal tissues. Now the normal cells are not receiving the nutrients they need, and waste products are beginning to add up. The normal cells begin to atrophy and die. Once this happens, you get tumor cell replacement in this new available space. The second method is tumor cell motility. Tumor cells tend to separate from the main tumor and migrate into surrounding normal tissue. This is due to two factors. The first is reduced adhesiveness. Tumor cells tend to be easily released or removed from the primary mass. Also, tumor cells produce enzymes that act to degrade the basement membrane and the extracellular matrix. This then provides a path of least resistance, and it becomes easy for them to spread. The third method is chemotaxis. These are chemical stimuli that pull tumor cells into the normal tissue. There are three sources of these chemical stimuli. One is from normal cell metabolism. Another is from the basement membrane and the extracellular matrix degradation byproducts as the tumor is breaking these down. And thirdly, they can be released by other tumor cells. Gross invasion means that the tumor cells tend to follow the path of least resistance. High resistance tissues are things such as bone, fascia, thick-walled arterioles, and the pericardial sac. This would be very difficult for tumors to spread through these tissues. Low resistance or least resistance areas are the abdominal cavity and the peritoneal surfaces. This graph summarizes the means of spread. Tumor can bind to the extracellular matrix and the basement membrane, resulting in the release of enzymes that degrade these structures, allowing tumor cells to motility to the tumor cells, leading to invasion. Tumors tend to have reduced cell adhesion, making them motile, releasing cells, and invading other tissues. Invading tumor cells will secrete chemotactic factors, so too will tissue metabolism byproducts secrete chemotactic factors, and these factors also come from the breakdown of the extracellular matrix. Chemotactic factors also enhance motility, leading to invasion. Tumor metastasis, or the ability of a tumor to spread from the primary site, is another behavior of tumors. Tumor metastases occur via three methods: embolism, body cavities, and iatrogenic. The first of these methods is embolism. Tumor cells spread as an embolism in the blood or lymph vessels. This starts by direct invasion of the vessels by tumor cells. Once in the blood vessel, growth will continue. Then clumps begin to break off due to their decreased adhesiveness property. These clumps will be transported in the blood and lymph until they become trapped. Once they're trapped, they resume their growth. As growth proceeds, they invade the vessel wall once again and gain access into the secondary site. This is illustrated in this picture. Here's our tumor. It's invaded the blood vessel wall and begins to grow. It sheds off clumps of tissues that become trapped. Once they're trapped, they start to grow. Once again, work their way through the vessel wall and gain access into the secondary site. In veins, emboli have very easy access to the right side of the heart and then into the pulmonary circulation. They become trapped in the small terminal vessels of the lungs. The lung is a common site for metastases. In the abdominal organs, they drain into the hepatic system. Emboli become trapped in the small liver sinusoids. The liver is a common site for metastases from stomach and intestinal tumors. Arteries have thicker walls, so they are much more difficult to penetrate. They do tend to have a more disseminated metastases to organs of high vascularity. For example, the lungs. Cells enter the left heart and have a high metastatic rate to the brain and to the kidney. In lymph vessels, they have very thin walls just like the veins, so they are easy to penetrate. There are three mechanisms for metastatic penetration of the lymph vessels. One, lymph nodes will trap the emboli, and this will allow the cells to grow and invade and become a source of new emboli for the next lymph node in the chain. Metastatic lymph nodes will block the normal flow of lymph. Now the lymph needs to be redirected, and this will provide a larger field of tumor embolization. Lymph nodes are also highly vascularized and provide communication to the blood vessels for additional blood vessel metastases. And this picture illustrates how lymph metastases occur. The tumor will invade the lymph vessel, producing an emboli in the lymph node. The tumor will grow within that lymph node. This can lead to further embolization, leading to sequential metastases down the chain. It can obstruct lymph flow, which then disperses it to other lymphatic channels, or they can invade the blood vessels, leading to distant metastases. Second way for metastases to occur is through body cavities. Tumor cells will leave the primary organ, float through a cavity, and settle on a secondary organ. For example, with pancreatic tumors, pancreas tumor cells will fall into the pelvis and they can form a shelf-like tumor mass. And then the third way for metastases is iatrogenic. This is the spread of tumor cells by medical intervention. This is a very rare way that metastases occur. This would occur, for example, by the breakage of an abdominal tumor, which would allow cells to spill into the abdomen. What are some factors that will affect whether or not a secondary tumor will grow at that secondary site? Only about 1 in 1,000 shed primary tumor cells will actually survive. This is due to the turbulent blood flow, which causes physical disruption of the cells, and also due to the host defense mechanisms that will attack these cells because they recognize them as being foreign. Clumps of 5 to 10 tumor cells have a much better chance of survival. They tend to pick up a coat of fibrin around them, and this protects them from the turbulence as well as from our body's defense mechanisms. There are 4 factors that will influence successful secondary tumor growth. The first is specific endothelial binding by the tumor cells to the endothelium of vessels where they become lodged. They tend to match receptor endothelium adhesion molecules. Second is their ability to produce selective tumor enzymes that degrade the vessel basement membrane and extracellular matrix. Thirdly is chemotaxis. The secondary site metabolic byproducts will actually attract selective tumor cells. And lastly, variable growth factors at the secondary site. They selectively support specific tumor cells. And these 4 factors are illustrated here. The tumor cell will adhere to the endothelium, causing the endothelium to retract. This will expose subendothelial tissues, leading to access into the secondary site for secondary tumor growth. As a tumor cell adheres to the endothelium, it can produce enzymes which degrade the basement membrane and extracellular matrix, again allowing access to the secondary site. Different chemotactic factors can lure them to the secondary site, and local growth factors can also allow for secondary tumor growth. Next, we need to look at the effects that tumors have on the body. These are both minor and major, local as well as systemic effects. The first effect is tissue destruction. This is a local reaction to the tumor expansion into normal tissue. It affects the normal tissue's functions, leading to tissue death. You will see a decline in the number of functioning normal cells. The normal cells will begin to atrophy in response to tumor pressure. The blood vessels that supply the normal tissue will become compressed. As a result of this, the normal tissue receives less nutrition and waste products begin to accumulate. All of this will lead to tissue death. A second effect is obstruction. This is direct invasion or external compression of a duct or a passage, which results in abnormal organ function, flow, or movement. Examples of this would be with bronchial tumors, you would have obstructed ventilation. With esophageal tumors, you would see obstructed ability to swallow. A third effect is infection. This is often associated with the presence of a tumor. Infections result from the suppression of the immune system with bone marrow and lymphoid tissue involvement. It could also be due to disruption of the body's surface and normal barriers to organisms. For example, if you disrupt the skin or have openings in the skin, this will allow Staph aureus access into the body to cause an infection. Tumor obstruction prevents normal elimination. For example, lung tumors reduce the normal ciliary movements, which can lead to pneumonia. And infection could be due to perforation of the intestinal wall with spillage of fecal material into the abdomen, and this can lead to peritonitis. Tumors can also have an effect on the blood. This might be a direct effect, which would be hemorrhaging due to ruptured vessels or GI bleeding, or it could be an indirect effect due to an effect on the bone marrow. Some indirect effects include leukopenia. Leukopenia is an inadequate white blood cell production, and this will lower the body's ability to fight infection. Another indirect effect is anemia. Anemia might be due to a decreased erythropoietin production. This will result in fewer red cells being produced. Anemia is also seen with GI tumors. GI tumors prevent adequate iron, vitamin B12, purine, and folate absorption. All of these materials are needed for normal red blood cell production. Tumors also have a very high affinity for purines and folate to support their growth. So if they are absorbing these products, they are less available to support normal red blood cell production. Anemia may also be due to the destruction of red blood cells by the tumor themselves and the inability of the bone marrow to replace them. A third indirect effect is polycythemia. This is seen in renal tumors due to an increase in the amount of erythropoietin. These effects are summarized in this flow chart. Tumor growth in the GI tract can result in reduced absorption, so there's less iron and B12 for reduced numbers of red blood cells. Bone marrow and non-marrow tumor growth or tumors that grow in the bone marrow themselves can have similar effects. You will see depletion of folate and purines and a release of marrow suppressants, which will suppress the bone marrow. This will lead to reduced red cells, reduced white cells, and reduced number of platelets. Reduced red cells will lead to anemia. Reduced white cells lead to an increased risk of infection. And reduced platelets will lead to various blood coagulation disorders. Another effect of tumors is pain. There is a wide range of pain associated with tumors. It could be constant pain versus intermittent pain, mild pain to severe pain. Pain is associated with tumor growth. Main reason is due to direct invasion of the tumor into or onto the nerves. Also, increased pressure and tension that are placed on the nerve endings as the tumor grows. And lastly, pain is due to the involvement of highly sensitive organs such as the bone. Another effect is cachexia. This is often associated with advanced malignancies. This is a syndrome of general weakness, fever, wasting, anorexia, and pallor. This is due to the accumulation of the previously discussed tumor effects. Cachectin, this is tumor necrotizing or necrosing factor alpha. This is a specific growth factor that leads to an increased metabolic consumption of nutrients and the accumulation of waste products. Other contributing factors include toxins and necrotic debris that are unable to be removed. These will begin to build up to toxic levels. Tumor progression also steals nutrients from the normal body tissues. Another effect are hormonal effect. Tumors of hormone-secreting organs will produce abnormal amounts of these hormones with potentially serious consequences. For example, islet cell adenoma of the pancreas will result in an increase in insulin secretion. This results in pushing potassium intracellularly, resulting in hypokalemia, low potassium in the blood. This can lead to coma and eventually to death. Again, this flowchart summarizes all of the various tumor effects that we have seen. As the tumor grows, we can see hormonal effects causing various systemic disorders, tissue destruction resulting in loss of function, ulceration leading to hemorrhage and anemia, obstruction, which can cause pain and decreased flow or movement. We can have marrow effects leading to decreased resistance, which can cause an increased risk of infection and a decrease in red cell production. Next, we need to look at oncogenesis. The term oncogenesis means tumor formation. It involves alteration in cellular reproduction and differentiation. Oncogenesis is based on chromosomal information that governs cell growth and differentiation. This is the place where transformation arises. One factor that plays a role in oncogenesis is heredity. Unfortunately, very little is known about the hereditary influence on oncogenesis. Only a few tumors have hereditary potential. These include ovary, breast, and colon. These tumors, or these types of cancers, will allow possible incidence prediction for future generations. Many times, these tumors are affected by cultural and environmental differences, so it becomes very difficult to predict. Environmental factors, their effects are much more well known. Evidence points to alterations in DNA due to various environmental factors. One type of factor are physical agents. Physical agents tend to damage nucleic acids and suppress anti-tumor defenses. The most notable of the physical agents is radiation. Radiation comes in two forms, one being UV radiation. This is from sun exposure, and we know that exposure to sun over time leads to an increased incidence of skin cancer. Ionizing radiation is industrial radiation as well as the radiation from medical exposures, such as X-rays, dental X-rays, and also what miners are exposed to. Another environmental factor are viruses. DNA is interacted with by viruses. We know that many viruses will interact with DNA and interrupt the normal DNA functioning. Therefore, it is probable that they can cause a neoplastic change. However, few tumors show strong evidence of a viral link. Some tumors have viral associations, but none are absolute. We do know that cervical cancer is the result of HPV, human papillomavirus. Liver cancer can be caused by the hepatitis B virus, and Burkitt's lymphoma is the result of the Epstein-Barr virus. Thirdly, as with environmental factors, there are various environmental chemicals. These chemicals have been known as neoplastic transformers for many years. They include industrial byproducts, food, clothing, medicines, and cosmetics. The problem with these, though, is that you need prolonged exposure over time, and there is no association with a single one-time exposure. This summarizes the various factors that can result in oncogenesis. Radiation, viruses, and environmental chemicals can all have an effect on a normal cell, resulting in a neoplastic transformation. How does oncogenesis occur? What are the mechanisms involved in oncogenesis? Well, we need two things to occur. The first is initiation. This is the process where essential cellular change is first introduced by some distinct inciting factor. Usually, you need more than one initiation event. Initiation events will result in an irreversible change, but actual tumor development depends on the second factor, which is a promoter. Promotion, this involves a factor that will accelerate the initial neoplastic change into a significant growth. One also needs prolonged exposure to this promoter. Examples of promoters would be hormones such as estrogen, leading to an increased risk of breast cancer, and a high-fat diet can lead to an increased risk of colon cancer. Now, the mechanisms, how it happens, if you are exposed to the initiator alone, you will see a very low rate of neoplastic change. If you are exposed to the promoter alone, there will be no change at all. You need initiator exposure followed by promoter exposure for neoplastic formation and growth. You also need repeated initiator exposure to overcome the body's natural ability to repair its damaged DNA. And this is illustrated in this chart. If you have one exposure to the initiator, your chance of tumor growth will be none. If you are exposed to just the promoter, even multiple exposures to the promoter, your risk of tumor growth is none. If you have multiple exposures to the initiator, but no exposure to the promoter, you will have a very slight risk of tumor growth. If you have exposure to the initiator, followed by the promoter, you have a much greater risk of tumor growth. Even if there is a long gap between when you were exposed to the initiator, followed by the promoter, this too will lead to an increased risk of tumor growth. If you are exposed to the promoter first, followed by the initiator, you will have no risk of tumor growth. Next, we need to look at the different types of cancers. First are solid tumors. These are organ-based cancers. You are able to touch them and feel them. These would be tumors, for example, that are found in the lung, in the breast, in the prostate, and the colon. They tend to be surgically manageable, and they have variable chemotherapy and radiation response rates. Hematologic cancers are those of blood or lymphatic origin. You are unable to touch or feel them. One type of hematologic cancer is leukemia. This is the #1 malignant tumor of leukocyte precursors in the bone marrow. Bone marrow proliferation is so rapid in leukemia that immature white blood cells end up spilling into the blood. The consequences of this are that not enough mature neutrophils are produced to help the body fight infection, so you tend to see an increased risk of infection. Also, anemia develops due to a decreased ability to produce red blood cells because all the energy is going into the production of these white cells. In later stages, invasion of the bony cavities occurs, causing pain and distinct metastases. Classifications of leukemia. Acute leukemia means it has a rapid onset and progression. It has very severe signs and symptoms with the presence of more immature cells. Chronic leukemia has a gradual onset and progression. Symptoms and signs tend to be more mild, and there are more mature cells present. There are two lines of differentiation with leukemias: myeloid versus granulocytic, and lymphocytic versus lymphoblastic. We add these into the definitions of leukemia. First, we have acute lymphocytic leukemia, ALL. This is common in children and adolescents. This is the most common malignancy seen in children. You will see decreased erythropoiesis, which will lead to anemia, weakness, and fatigue. You also see decreased platelets, which leads to an increased risk of bleeding. There are also a decreased number of mature white blood cells, which leads to an increased risk of infection. Acute lymphocytic leukemia has about a 50% cure rate with chemotherapy and bone marrow transplant. Acute myoblastic leukemia, AML. This is common in adolescents up to about 40 years of age. It has a similar clinical appearance to acute lymphocytic leukemia, with the addition of chromosomal abnormalities. This form of leukemia has a very poor prognosis. 75% experience a recurrence rate after about 18 months after therapy. Chronic lymphocytic leukemia, CLL. This is the most common of all types of leukemia. It is most prevalent in those over 50 years of age. This tumor is of a B cell or B lymphocyte origin. Remember that our B cells are the ones that are responsible for producing antibodies to help us fight infection. As a result, we have adequate numbers of B cells, but they are poor functioning. As we see a decrease in antibody production with an increased risk of bacterial infections. This form of leukemia has a gradual onset of fatigue, weight loss, anorexia, and lymphadenopathy. Prolonged life expectancy does occur with as long as 10 years after diagnosis with chemotherapy. Chronic myoblastic leukemia, CML. This is common in those between the ages of 25 and 60. Here we see white blood cell numbers greater than 100,000. The liver becomes enlarged as well as the spleen due to increased white blood cell infiltration. It has a similar presentation as CLL. Another thing we see that differentiates the two is the appearance of the Philadelphia chromosome. This is chromosome number 22, and in chronic myeloblastic leukemia, the Philadelphia chromosome is damaged. This is seen in about 90% of all cases. These patients also typically enter into what is known as blast crisis. This is a rapid production of immature blast cells resembling AML. This form of leukemia has a very poor prognosis, especially if they enter into blast crisis. Malignant lymphomas are solid tumors arising in lymphoid tissue. They act like hematologic tumors by their ability to invade the bone marrow, and like a solid tumor by its local invasiveness and organ compression. With prolonged growth, the bone marrow and lymphoid tissue becomes replaced with the cancerous tumors. This leads to immune deficiencies, anemia, infection, and lymph node enlargement. There are two subgroups of these malignant lymphomas. The first is Hodgkin's lymphoma. This is a rare form of lymphoma, typical in adolescents and young adults. It presents typically as a single lymph node, usually in the cervical region, and then it very rapidly spreads systemically to the liver, the spleen, and other lymph nodes. You will see fatigue, wasting, and fever in these patients. Hodgkin's lymphoma is staged, and the staging depends on the number of lymph nodes involved, their location, and the organs involved. The higher the staging, meaning the more lymph nodes involved, the worse the prognosis is. The second subgroup is non-Hodgkin's lymphoma. This is less regulated and more erratic than Hodgkin's. It too often enters into the blood and acts like leukemias. The prognosis of non-Hodgkin's is not as clearly related to staging as Hodgkin's is. The staging here is more complicated. It is based on the number of lymph nodes involved, the histology, aggressiveness of the tumor, and clinical symptoms.